Welcome today to the HHQI's Underserved Population Network call. We're glad that you were able to take time out of your day today to join us. The call is being recorded for those that were unable to join today and that can listen to the recording. We're very excited on our topic today on community mental health on wheels, and we have two excellent presentations today from an organization that is really ahead of the game with behavioral health and mental health in their communities. Today we are going to be using both polling again, so we're going to be putting a polling question up in just a minute. We also have our Q&A or chat feature. So we'd like you to, your lines are muted, so we would like you to put any of your questions in the chat feature or the Q&A, and we will use those at the end for the Q&A question. We do have some announcements that we always follow up, and we do have a new breaking announcement that I'm excited to add on that's not in our slides to tell you about when we get towards the end. So we're going to go ahead and turn to the next slide, and we're going to ask Misty Dyke to go ahead and put our first polling question up. So it's, does your agency have a formalized mental health program? So if you could answer one of those responses, and we'll come back and take a look at the responses later when we have our next polling question. But I'd like to go ahead and move on to the next slide so I can introduce our speakers for today. We are very fortunate to have two speakers from the Visiting Nurse Association in Ohio, based out of Cleveland, Ohio. And we have Amy Silball, and she's the clinical manager in the Visiting Nurse Association of Ohio's Mental Health Department in Cleveland area. She received her Bachelor's of Nursing at the University of Cincinnati School of Nursing in Ohio. She has over 15 years of clinical experience in both acute and community settings, but most of her career has been in the mental health field. She is currently a qualified dementia care specialist through the Alzheimer's Foundation of America. Also joining us today is Gary Mahoney. He is currently a community mental health nurse with the VNA of Ohio. He began his career actually with a Bachelor's of Science in Technical Education as a habituation specialist. Get that one out. Say that 3 times. And then returned to nursing school. So nursing's his second career. He has included emergency medicine, but the past 9 years have been in community mental health. He currently coordinates and manages the Visiting Nurse Association of Ohio's Psychiatric Bridge program. I was very fortunate to hear both of them speak at the International Home Care Nurses Association meeting this summer, and I'm very pleased to have them present today. So with that, I'm going to turn it over to Amy and Gary.
Thank you very much, Misty. We're very happy to be with you all today to talk about our very exciting mental health program. We like to refer to it as Community Mental Health on Wheels. We're 100% outreach. No clients come to our building, we go to them. We find them wherever they are, be it a house, group home, apartment, family member's home. We go to homeless shelters. So we really, our whole department is on wheels. So what the mental health nurse's main focus is we provide assessment, which is not only assessment just of their psychiatric condition, but also any medical comorbidity that they may have. What we find is that when most patients come to us, they not only have a severe mental illness, but they also have lung problems, cardiac problems, diabetes, they're overweight. So we have a myriad of issues to deal with when patients come to us. The other thing we focus on is pharmacologic management, and what that refers to is dealing with everything medication-based. And again, not only their psychiatric medications, but anything for medical conditions, and that includes linking them to primary care, dentistry, specialists, eye exams, just a myriad of things. They require a lot of medication teaching, not only to the client, but the family member as well, so that's wrapped up in pharmacologic management too. We also provide counseling. The nurses, while they are not trained counselors or certified counselors, they do have a lot of experience doing work with grief, depression and anxiety management, behavioral modification techniques, OCD, and we've really gotten a lot into the hoarding business lately. We're finding that a lot. So the nurses are skilled counselors. We also have social workers as well that do provide the in-depth individual counseling. And again, to qualify for our program, you do have to be severely mentally disabled, and we'll talk more about what that means and the kind of different diagnostic groups that we serve. So when a patient is referred to VNA, we really pride ourselves on at least contacting the patient within the first 24 hours. Usually we're out at their home within 2 days of the referral. Sometimes we do hit snags with that. With the mental health population, a lot of times they're a very transient population, and there are a lot of issues with noncompliance. So a lot of times it will take us a few days to actually locate someone. They may have gone to a different address, or they may not have an address. They may be homeless, so we have to track them down. But I do like to call our nurses Sherlock Holmes. They will track you down. They will find you. They are very diligent with that. A lot of our clients do not have phones, so we have to work around that. But again, we will find you if we are at all able. Again, we talked about the supportive counseling and coaching. We focus on the recovery management plan of care. There is no cure for mental illness, so what we want to have happen is to have the person recover as much as possible, to be in the least restrictive environment and to prevent rehospitalization. So when we create a plan of care with the client, it's not sort of driven by the nurse, it's driven by the client. So we'll sit down with them and we'll collaboratively talk about goals that they have for care and what they want to see happen. And that may be very different from what the nurse's idea of care may be. The nurse may want to stabilize the client on their medicine, and the client may want to be the President of the United States. That happened last week. So we have to come to a happy medium and try to figure out how we can best work together. So we want to focus on recovery and the recovery process. And then the other thing that we really do well is link clients to activities and resources in the community. A lot of times they will need a case manager for assistance with transportation, not only to appointments but to the grocery store to take care of different business like that. Again, they may need a doctor. They may have legal issues. They may have a whole bunch of other issues that we can't ignore when we're in the home. So we link them to whatever services they may need if we don't provide them. The services that we provide and the different diagnostic groups that we service, this is not by any means a total list of every diagnosis that we see, but it's sort of the major categories. Schizophrenia is the #1 diagnosis for the mental health department, and actually it's the #1 diagnosis for the entire VNA of Ohio agency. We've serviced a lot of people with this diagnosis. Mood disorders, that would include bipolar disorder. We have a lot of clients that have Alzheimer's and dementia. The silver tsunami is coming, and we are seeing a real big uptick in clients that are being referred for Alzheimer's and dementia cognitive issues. Anxiety disorders, adjustment disorders, people who are having a hard time adjusting to maybe a change in life, maybe they've lost a spouse, or a lot of times we'll see this with the Alzheimer's dementia population. They will have lived in their home for 50 years, will have lost a spouse and cannot live independently anymore, so they will go into an assisted living facility. They may then develop maybe a situational depression. They may isolate to their room. They may not want to be involved in activities at the nursing home. So we kind of go in and see what's going on. If they need medication, short-term or long-term, we can assist with that, and we kind of help them get used to their new environment. And we also take care of clients that have dual diagnosis, which is not only having a mental health disorder, but also a co-occurring substance abuse problem. Core Centers of Excellence, this is things that we do really well at VNA. We kind of pride ourselves on this. We talked about transition and symptom stabilization post-hospitalization. Most of the clients that we get, about 41%, come from hospitals. So our main goal when we get someone from a hospital is that they don't go back there. Hospitals are really looking at right now 30-day rehospitalization rates, and we're really keyed in on that here at VNA. Not only do we not want the patient to go back into the hospital, but when any person with severe mental illness has a decompensation, we call it, where they're sick enough to go back into the hospital, they actually have brain damage. So we want to prevent that at all costs because it's harder for them to get back to what we call their baseline, their sort of normal functional level. And every time they have a decompensation, they never quite get back to where they were. So what we want to do is look at their medications, make sure they're taking them, see if the medications are correct, if they need to be on something else, if they're on too much medication, and really kind of support them in the home. A lot of times we'll make 2 visits in the week that they're home from the hospital to make sure that they're doing okay. The other thing that we do well is, I talked about this a little bit before, but managing not only the mental illness, but physical illness as well. A lot of the psychotropic medications that clients take for their illness cause physical disease. It can cause obesity, diabetes, hyperlipidemia, and hypertension. So we actually have a specialized program here at VNA that monitors those different parameters. We do weights, we do different blood tests, we check for blood glucose and stuff like that. And we weigh the patient, we do vital signs, and then we report that back to the physician. And then we rely on physician orders and follow-up, and we take care of the patients that way too. We've identified a lot of people with diabetes that they didn't even know they had because of this program, so it's really, really important. We do blood work in the home. There's a lot of different psychiatric drugs that require blood work to make sure that they are effective and not harming the patient. And a lot of times what they were finding is that the clients were not going to the doctor's office to get these drugs or these blood monitoring tests done, so we just go into the home, take care of it, and make sure the clients are healthy. We also have, again, a very robust elder mental health service population. We look at medication misuse, abuse. There's a lot of polypharmacy that goes on with this population, and there's a lot of medical doctors prescribing psychotropic medications for the elderly because they may be agitated or having problems sleeping, especially in the evening. And a lot of those medications are very dangerous for them to be taking. So we go in and we look at that. There's a big problem with elder depression, again, the cognitive impairment piece. We really check for suicide risk. White males over the age of 80 are at the highest risk for suicide. So we have a suicide depression screen that we use. We also have a depression scale that we use on admission. And then we also have a mini mental status exam. We'll do all those on admission, and we'll do them every 60 days so we can continue to monitor to see if there's any changes. If we do notice a change, we'll of course report that back to the physician and go from there. There's a whole cadre of nurses on the mental health team that are certified in dementia care and disease management of this. So who benefits from VNA mental health services? Some of the things we'd like to highlight are someone who has a new diagnosis of mental illness. Gary will talk about that more with his program. He gets a lot of people who have what we call their first break. They may be 18, 19, 20 years old and having their first bout of mental illness. But a lot of times mental illness is not recognized until later on in life. So if someone has a new diagnosis, that's a great reason to bring us in. If they have a history of frequent rehospitalizations, if they have a problem with compliance or not adherent to treatment. Decompensation, I talked a little bit about if they're not really sick enough to go into the hospital, but they're just not doing well, they're just not cutting it in their environment. They may be taking their medication, but they're not taking it every day. You just know they're not looking good and they're not doing good. That's a great reason for us to come in. And then mental health and physical health comorbidity management. To be eligible for VNA services, you have to have a psychiatric problem that's manifested in part by refusal to leave the home environment. Now, you can leave the home, you can go to bingo, you can go to church, you can go to doctor's appointments. What you can't do is be gainfully employed and be driving a car. So you have to be what's called psychiatrically homebound. A lot of times our clients will leave the home a lot, but it is for unsafe reasons. It's to buy drugs, it's to wander the street, it's to do unsavory things that if they were stable, they would never do otherwise. So again, to get home care, to have a nurse come out to your home and have insurance pay for it, your illness has to be severe. So that's part of our criteria. And you do not have to have a concurrent physical limitation to be service eligible. You just have to have a primary diagnosis of mental illness. So our mental health team, we serve approximately 1,100 patients annually. We run a general active daily census of about 1,000 patients. We are the largest subset of teams within the VNA. VNA also has med-surg teams. We have rehab, we have hospice, we have home care aides, we have social work, we have private duty. So out of all those different teams, the mental health team is the largest. We have 35 certified psychiatric nurses. We have 2 mental health home care aides. These are STNAs that have been specially trained and have a bunch of psychiatric experience. And what they do is they go into the home and they really act as sort of a life coach for the client. Again, we don't want to enable any client. We don't want to go in there and do a bath if they don't need it or help them organize their environment if they don't need it, but they show them how to help themselves, which is really wonderful. We do have a social worker, and then we do have a psychiatrist, which Gary will go into more. We are a national leader in the delivery of community-based mental health nursing care. We are the largest nurse-based mental health home care in the state of Ohio. We are certified both by the Ohio Department of Health and by JACO. The nice thing about VNA is we have a lot of interdisciplinary staff. So if your patient's in mental health and has a wound, we can, forward them to the skilled nursing department for management of that. If they break a hip, we can get them for physical therapy. We use occupational therapy and speech therapy a lot with our clients. Occupational therapy will really go in and help them, even organize like budgets and organize their kitchen and help with doing activities of daily living. And speech really works with people that have Alzheimer's and dementia with cognitive issues, visual cueing. We found that is really helpful. Our nurses are certified by the ANCC for psychiatric nursing, and they also have to be certified to even work here by Palmetto GBA, which is a Medicare subsidiary. So in summary, we support care that supports the recovery process model. Again, there's no cure for mental illness. So the nice thing about our services is as long as we can demonstrate a skilled need for the patient, medication monitoring, symptom stabilization, et cetera, we can see the patient ongoing. We look at the client every 60 days in 60-day intervals called CERT periods, and we assess how they're doing. If we feel like there's a need for ongoing care, we get a doctor's order and we can continue ad infinitum, really, as long as the client needs us. We've had clients since the inception of the program in 1992, and we'll probably have them, unfortunately, until they pass away. So this, again, is not a time-limited service. The average stay on our service is about 6 months. Some people, again, longer, some people shorter. So we advocate for individual directed recovery. Again, the client kind of drives the bus and sets their goals. Again, we do a lot of education, not only with the client, but with family members. A lot of times there's a lot of stigma that is involved with mental illness, and there's a lot of education that needs to be disseminated so that the family can be supportive of the client and really understand what's going on. And again, we really support do the supportive services in the community and do linkage. So our main goal, of course, is to prevent rehospitalization. In-home psychiatric services are proven effective in reducing hospital admission and length of stay. 80.7% of patients with mental health needs who are referred to a hospital could be treated at home. They are less likely to be readmitted, 11.8% with home care versus 45.9% without.
Thank you, Amy. I hope a lot of you, there's great points and hopefully lots of questions. So make sure you do put your questions into the Q&A. We're going to go ahead and start polling question number 2, and then I'll tell you what polling question number 1 is before we resume with having Gary present. So number 2 is up, and does your agency collect data to show outcomes for your mental health patients, such as the readmission rates that Amy just spoke about, or any other type of data that you might collect? And from our first polling question, for the people that did respond, we had 27% of the agencies responding said yes, they have a mental health program. We had 3% that are developing one, and we had 43% that said no, they do not have a program at this time. So I think we do see that a lot through a national selection. Some agencies find this to be an area that they have a hard time staffing. They don't have the expertise, but you can see already from what Amy has talked about how qualified their staff members are required to be as part of this program and their certifications. So we're going to go ahead and change to the next slide and go ahead and have Gary present.
Oops. Okay. Where's my stuff? Here we go. Hi, everybody. Again, my name is Gary Mahoney, and I run what would be a specialized area within the mental health department called the VNA Psychiatric Bridge Program. This program is grant funded through our Cuyahoga County Board of Alcohol, Drug Addiction, and Mental Health Services, which covers all of the Cleveland area and some surrounding areas. Our program provides immediate interim services for patients following discharge from North Coast Behavioral Health, which is our state hospital. Typically, upon discharge, clients are only given 14 days of their current medications. In many cases, the client's appointment with their respective community mental health agency exceeds the supply of medications that were given. So what happens is the client runs out of medications and subsequently becomes non-compliant and typically decompensates and ends up back in the hospital. Unfortunately, the time from discharge from the hospital to scheduled visits with their community agency, the client essentially has no psychiatrist to go to in order to obtain more medications. The hospital psychiatrist won't give refills, won't give any extra medications, and the agency psychiatrist who hasn't met the client yet isn't willing to write either. So what was happening is we had a lot of clients that were being readmitted because they were off of their medications through no fault of their own and decompensated. The clients in my program have no insurance in order to obtain medications and typically have no income as well. This program was developed in 2005 in response to that readmission rate at North Coast Behavioral Health. And in response to the problem, the Psychiatric Bridge Program was developed, and the grant money was given to our agency in order to satisfy the need of those individuals that needed that help. Clients that are referred have a history of multiple readmissions, usually have poor medication compliance and poor follow-up as well with the community agency that they're assigned to. Our goal is to prevent that revolving door, that readmission constantly back and forth to and from the hospital. Our program consists of two people, a psychiatrist who is Dr. Helen Defy that works here at the VNA, and a mental health registered nurse. And basically, what we have here is an uninsured individual who is scaled, which I'll go into in a little bit, to the community mental health agency. Or a client who's readmitted within 30 days, or that follow-up appointment to their mental health agency that they're linked to in the community is greater than 2 weeks out for that medication supply that they're going to be given. In our particular program, the client has to be a Cuyahoga County resident and must have a psychiatric diagnosis or depression with psychotic features or suicide attempts or recurring depression. So basically, the amount of meds, I'm sorry. Hang on, a little technical difficulty. Yeah, let me just submit that. Here we go. 2009, the SCALE program was developed. And what the SCALE program is, it's for individuals who are seeking mental health services, but they don't have any form of insurance and often have no form of income as well. A client can go through the SCALE process one of two ways. First, the client can have the SCALE process initiated in the hospital or a client can be scaled in the community. For example, if someone is in need of mental health services and is not hospitalized, he or she can call to begin the scale process with an initial phone screening. Following the phone screening, the client will receive an appointment for a more thorough assessment, a diagnostic assessment, at one of our area agencies, Connections, Health, Wellness, and Advocacy. Now, this is the process for our county. It's been centralized to this particular agency. Basically, the agency will then determine a level of care and link the client with one of the agencies within our area, depending on availability. The client will then be given a date and time for linkage with that agency in the community. Just like our regular mental health here in our department, contact is made within 24 to 48 hours after hospital discharge. And pharmacologic management resources, we provide access and assistance with linkage to their community mental health center. And the client is able to maintain medication compliance through our weekly visits. Basically, our bridge program psychiatrist maintains relationships with most of our major pharmaceutical companies in order to receive samples or vouchers for 14-day free trials that will oftentimes bridge that gap until we get the client linked with their respective agency. And at that point, most of the agencies here have a central pharmacy that, until they get maybe some insurance or they get them linked with different benefits, can provide those medications for free. We also use patient assistance programs to help clients maintain medication compliance. For example, Johnson & Johnson, they have a program for free Risperdal tablets or Consta or both for up to 12 months free. Abbott has a similar program for Depakote. And really, most medications, if you go to their website, they have similar programs for people without insurance or low income. So the results, 50% of all patients admitted to psychiatric hospitals are readmission. 10% are readmitted within a month of discharge. This is why we will receive those referrals also that are 30-day readmits to try and stop that cycle. You know, basically, also with our weekly home visits, this is one of the biggest part of why the program is successful. Our home visits provide us with better insight into the client's overall well-being. The client's environment gives us a better understanding or picture of what's going on with the client. Home presentation, including family or roommates, can help the team be more aware of the client's situation. For example, drugs in the home, abuse, or any other number of things can impede the client's recovery. I had given an example at one point. We had a particular case where the client was doing pretty well in the hospital. I met with her prior to discharge, which I always do when someone's in the state hospital. I go every Wednesday to what's called a discharge meeting at our state hospital, and then receive the referrals for who we may be being referred. And I go meet them, introduce myself, explain what the program's about, so that when I call when they're out, they know who I am and what's going on. And I do that prior to discharge. Well, in this particular case, the client was discharged, doing very well. We went to see her 3 days later at her request. She wanted to take care of some things because she had been in the hospital for over a month. And by the time we got there, she had decompensated, and she was pretty much like a different person. She was very hostile and argumentative, and clearly she was delusional. She reported medication compliance, and the medicine added up. We always back count the medication just to, see what's going on. But upon further investigation, we found the client was crushing and snorting Depakote, and she said she was taking her Risperdal, but only PRN for sleep, and she was inserting the Prozac rectally. The psychiatrist, Dr. Define, made some changes. The client was changed to Risperdal constant injections, and it turned the client around fairly quickly and averted another hospitalization. That was one of our better success stories. Our psychiatric bridge program readmission rate for clients that are discharged from North Coast Behavioral Health System is between 2 and 7%. And the bed cost is $565 per day. So we save quite a bit of money for the state hospital and the county in general. In 2012, 87% of those bridge program clients successfully transitioned to a community mental health center and did not go back in the hospital. In the first quarter of 2012, our rehospitalization rate was 4%. So we've had some pretty good success with this program and are pretty proud of it. We're going on our 8th year with the county board and North Coast Behavioral Health. Thank you.
Thank you, Gary. We're going to open up for questions here. So we want you to go ahead and type in any questions that you have related to any of the information from the presentation, or if you have a question for either Amy or for Gary, to put that into the chat feature or the Q&A, and we'll get those questions and facilitate those to the speakers. In the meantime, while I'm allowing you some time to do that, I'm going to go over the last polling question, which was, does your agency collect data to show outcomes for your mental health patients? And we had 15% of you had selected several different ones. 6% said 1 or 2 outcomes. So if you take those two groups together, that is about 21% of those that did answer this response are collecting outcomes. 9 aren't at this time, but 9%, but are in the process, and at this time 33% are not collecting data. But I hope that you see through the slides both from Amy and Gary why it's important to collect some type of data. And if you were on the up call from 2 weeks ago related to diabetes, again, it talked a lot about data and collecting data. But I think there were a lot of great points as to why you want to collect data. One is to show your success, and ultimately that means it's patient success, and you are affecting patient lives that you can track and trend. But the other way, I do believe that you would get a lot of clinician satisfaction in watching your trending and getting the numbers and reports that the Visiting Nurse Association of Ohio has been showing would be very validating for the work that I'm doing. But also think about your relationships in working with your hospitals, your payers, by being able to validate your successes and altering your practices and using the best practices. You're able to validate that to have a better working relationship and getting better payment with some Advantage Cares or through some other payers in your state, your medical assistants, et cetera. So I think it is essential to collect some type of data beyond just our regular outcomes that we use for Home Health Compare, because they really don't give you any good data for this type of population that you're working with. And we're going to, I see that Misty Dyke has already put our next question up. And what's the most difficult barrier that you have with your mental health populations in home health? And we're going to continue to watch for some questions. But while we're waiting, would either Amy or Gary, anything that you might like to add at this point while we're waiting for some questions?
I would like to add one point, something that has occurred since we submitted the PowerPoint. We have a new grant-funded program that is focusing on fourth-year psychiatric residents. We have partnered with University Hospitals of Cleveland, and we're doing it since our bridge program is so successful and our outcomes are so fantastic. What we're trying to do is replicate that for patients that don't come out of the state hospital, because there are plenty of patients that go into the hospital that don't have insurance that don't go into the state hospital. So we're trying to capture that population of patients. So the idea is that we get a fourth-year medical resident from UH Hospital in psychiatry, and he goes out just like Dr. Rafai with one of our nurses in the area, and they go out and they assess the patient and get them linked to a community mental health center. But again, in this area, I'm not sure how it is around the country, but in this area, the average wait time to get into a community mental health center is at least 6 to 8 weeks, if not longer in some cases. So if you are an uninsured individual who has severe mental illness, the chances of you going back into the hospital are quite high. So what we're trying to do is prevent that rehospitalization piece. We'll go out, assess you, see what medications you need. We provide samples as well, or we use patient assistance programs, $4 prescriptions at some of the area pharmacies. Some clients are able to afford that. And then we link them to the community mental health center. And the other thing that's really important is we make sure they go to that appointment. We don't just make the appointment and say, okay, go, bye. We make sure they have transportation. We make sure that they've actually attended the appointment and been linked. And then once they're linked, we kind of pull back and let the community mental health center take it from there. A lot of times the community mental health center will ask us to stay on with the patient because either the patient wants to because they really see the benefit of the service, or they want eyes and ears in that home for that patient on an ongoing basis. So we're pretty excited about that, and it's going well.
In addition to that, what the program, the Psychiatric Bridge program that we run through the hospital, the state hospital, that's been going on for 8 years, we also do with the community now. We just received that grant less than 12 months ago. Essentially, we're doing the same thing as hospital, except referrals are coming in through the community, so they weren't hospitalized, for example. And it's the same linkage process and the same process that we go through, that we go see them, Dr. Vafai and I, and take care of them and get the services started until they link with that community agency. And in most cases, they either have been out of medications for quite some time or not on any at all, and have had a prior diagnosis. So, we found a lot of success with that one as well.
And what's good about the Psychiatric Resident Grant Program is that we can service all of Northeast Ohio. There's about 7 counties in Northeast Ohio that the VNA regular service area can service. Gary's grant, unfortunately, is just written for Cuyahoga County. But with this new grant, we can kind of branch out and help other people that would have gone without otherwise. We also have an office in Mid-Ohio, in the middle part of the state, and they service the 24 counties south of Medina County and the north of Columbus, so they really take care of the middle part of the state, which is nice as well. More of a rural population.
Wonderful. We do have questions coming in, and please, everybody, still continue to write, and we're going to address those here in just a minute. One of the things that I was impressed earlier this year when I heard you both speak, and still extremely impressed with, when you come to a barrier or where patients seem to fall through the cracks, you don't look at it as a barrier. You just jump right in to figure out how to address that. How can we reach them? And even beyond your bridge program, it's like, but not everybody's coming through the hospital. So how do we get to these people? And just looking at any obstacle and just trying to figure out how to get around that. And you also work with pharmacy reps. I mean, you talked about going after grant programs, and I think that opportunities are going to continue to come your way, as well as others that are on the call, with our changes with our insurance programs through the new acts with our insurance exchanges, as well as the Medicaid expansions, although they're not in all states. But there are states that are even modifying their own Medicaid definitions and stuff at this time too. But let me do a couple questions, and then we'll come back to the next polling question, because it may also give us some good insight that Amy or Gary might have. But the first question we have is, this comes from Janet Noss. How do you balance physician orders between primary care and psychiatrists and keep both aware of med changes?
That's a great question, and that's something that the nurses struggle with, is keeping everybody on the same page. But again, that's the importance of home care, that's the importance of having the nurse go in. They will go, and we reconcile medications on every visit because things change so frequently with our patients. And a lot of our patients are so fragile So the nurse will be in contact not only with the psychiatrist, but with the medical doctor. We send out plans of care with medication lists that need to be signed by physicians. We have partnered with a pharmacy called Exact Care Pharmacy. They will send pharmacy representatives out to the home as well to assist with the medication reconciliation process. They will call the medical doctor. They will call the psychiatric doctor for refills, for discrepancies, and whatnot. The nurses are very skilled in this. It's probably what takes them the most time in their day, and a lot of times what is the main focus of the visit.
Great. There is another question from Michael Whitkey. His question is for Amy. I noticed within the last couple of your slides that you cited some information produced by NOC. I'm wondering, sorry, I have to scroll here a second, what year that data was published?
I believe that was published in 2008.
And I'm actually going to give, it's not a question, but it's actually a statement by Catherine Vanderhorst. She says, you should all be applauded for all that you have done. Please publish your data. Dr. Verna Carson and I published several studies in the 1990s. The more that is published, providers and payers will truly realize the value of this service. And all I have to say is amen to that.
Thank you very much. It's good to hear that. Thank you.
And it is important to, and that's part of going back to the collecting data piece. If you can collect that, if you're doing something good, it doesn't, and not something good, something extremely well, and agencies, every agency does something very well. If you can measure it and you can show how you're getting the results that you're doing, you do need to get that work highlighted. Unfortunately, in home health, we don't get as much highlighted, and we do not get enough research projects related to just home health. We have to use community-based or some other type of settings, best practices or evidence-based strategies. It is, you know, stand up and get yourself recognized if it's getting a success story written, it's getting an article submitted to a journal, but collecting data ties directly into validating your successes, and we all learn from each other. So that is extremely important to do.
Absolutely, and we do have a lot of exciting data coming through with our HCAPs, and we also have a lot of data that we track using our OASIS assessment, which is the main assessment we use for home care. So we track hospital readmission, we track improvement in functional status in ADLs, medication management, pain, we track falls that way. So we do have a lot of data. It's just kind of, you know, where do we go with it, what do we do with it, how do we share it, et cetera.
Well, very good. Well, Catherine's suggesting that you guys spend some time on getting some information published as well in your spare time. We have another we have another comment from Vicki Heiner, and she definitely reflects a lot of agencies that live in rural America. She said, we have very few services, no speech therapists, social workers, and have experienced no psychiatrists or have psychiatrists for short periods of time, and social workers are very difficult to come by. With one psychiatrist in our area, his availability is limited due to his caseload. Telemedicine has been tried in the past, but internet access is limited. Any thoughts?
That's a great question. We service mainly areas that have a lot of resources, at least up here in VNA of Ohio, Cleveland. Our Mid-Ohio office really services more rural populations. I know they are looking into telemedicine. The research that we've done up here, because we are trying to broaden our service area out into more rural areas, because what we're hearing the same feedback is that there's one psychiatrist, there's one hospital, and that's it for this whole large county, and there's such a need. The problem that we ran into with telemedicine was billing and kind of recouping that cost, and then also having the capital to buy the telemedicine equipment to kind of get started. That requires grant funding and stuff like that. It's something we're definitely looking at, and I think it is the way for the future. There are a lot of people that are doing it, but it's really a large investment, especially for a nonprofit like we are. We don't have a lot of extra funds sort of floating around.
Okay. And I will go look, Vicki, because I do know Vicki has sent us questions about rural before and has a lot of difficulty with it. But there was an article published, I just think, last week or the week before that showed success not in home health, again, obviously it's not written in a home health environment, but there has been great success with telemedicine working with psychiatric patients in the community. So I will find that, Vicki, and get that off to you. I know it was just in the last 2 weeks that I read the article. Okay, and I know there's another question hiding here that I'm having trouble finding. A colleague's trying to help me get it. And while we're looking for that question I have missed, please go ahead and you can still submit data, but let's take a look at our polling results, because this could also give us a little bit of food to talk about. What's the most difficult, what's the most difficult barrier you have with your mental health population in home health? With readmissions showed up as 6%, locating patients 13%, home health payment structures are 9%, and communicating and connecting with outpatient clinics, believe it or not, was 22%, which I thought some of the others may have been higher. Do you think, Gary or Amy, talk a little bit about your relationship with the clinics and how you are able to communicate well with them?
Well, basically, in what I do, at those weekly meetings that we have, those discharge meetings at the state hospital, there is a liaison point person from every one of the agencies. So, you know, I talk to them weekly. I have email and contact information. And oftentimes if there's a question or if there's communication needs, I can go through the liaison, and that person will then forward the question to the appropriate person, or they can answer it for me themselves. And that's helpful to develop that relationship with one point person from all the various agencies. And it really helps with communication. It helps foster patient success as well.
And Gary kind of has a unique situation where he does meet face-to-face with people, and he has designated contacts. A lot of times when we're calling a community mental health center or we're calling a hospital for follow-up, it is very difficult to get a hold of a live person. You almost never are able to talk to the doctor, him or herself. Getting return calls is very frustrating because those don't happen. And it's just part of home care, unfortunately.
And it's not just exclusive to the nurses or social workers. I know in some situations, Dr. Vafai has called other psychiatrists and hadn't received a call back for a day or two. So, you know, with schedules, and most psychiatrists work at various locations throughout the week, that's kind of a barrier as well, knowing which location they're at, and you know, the schedules are just so time-consuming. It's one after another, so that makes it challenging.
Well, we didn't say it would be easy, but you continue to plug away. But the more that you do, and again, that your success really leads to great relationships that opens lines of communications that you really, that other agencies find as a huge barrier for them. A couple other points that I have before we kind of wrap up, because I think we have covered all of our questions so far, is I think you brought up another great point about utilizing your therapy services, your OTs and your speech therapist for, especially for organizational skills and cognitive issues. A lot of times in home care, we get into that box that OT's there for ADLs and IADLs, and speech is for speech purely, but they really are trained and can do some specialized education and training to even further their skills. So if you have an OT that's really not up to par perhaps, they probably need to do some additional reading, some additional training, but they are such an underutilized service, OTs and speech therapists, that are great for this population. And you also talked about hoarders and having more and more hoarders. And if any of our participants that are on the call today did not participate in our June call, we had a 2-hour call on a webinar on compulsive hoarding by Dr. Tricia Ney and Tanya Miller, who is a physical therapist, and Dr. Ney. And they did an excellent presentation. It's still posted that you can watch the recording. It really talks about what's behind hoarding and how we can utilize home health, including therapy, and PT, OT, and speech were all included. I'm not sure speech was, but PT and OT were definitely included. And if you are a social worker online, you only have until Monday night, it will go off Monday night, that it was available for 2 hours of continuing ed that was through Celtic Healthcare that did the presentation for us. So that is under our archives, under HHQI site, under UP, and there is an archive site. And it's a fascinating to really understand behind, and it's just an overview for 2 hours on hoarding. You know, I think that's become such in the forefront because of the show on TV, but we've been living with it and dealing with patients for, you know, all of our careers. But now, you know, really seeing the treatment and the skill sets that can be developed and used even in home care. Well, I'm going to come back, and I don't think we have any additional questions. If you have any last comments, and then I'll do some announcements to finish up, Amy and Gary.
We just want to really thank you for having us on today and being able to share our services with such a large, broad, experienced population is really exciting for us. So thank you for the opportunity.
Thank you.
Well, we thank you very much for sharing and for your great success. And as Catherine said, make sure that you find time to publish, and we would, you know, love to be able to highlight other work that you're doing. And we will go ahead and turn to the next slide. And there we go. There are some additional resources on our topic today in the Underserved Population Best Practice Intervention Package. I have given you the pages between pages 47 and 50. We also, and that's on dealing with the underserved population, just some basic points, some good insights, some resources and tools for you. There's also a wonderful success story on behavioral health issues and home health care, a holistic approach. And Russell Herring and Heather Weeks from Assisted Care Home Health in, I believe it's North Carolina. I forgot to look that up again, but I'm pretty sure it's North Carolina, not South. And it's a very interesting article talking about where they found a deficit in their area was in their community, and they were able to move and not only have a home health component, but they have a community-based program as well, because they were trying to meet their needs of their community where these patients were located at. You can find all of those resources on HHQI under Education, Best Practices, and on the Underserved. Next slide. The Next Up Network webinar is going to be October the 9th, and the registration is open, and it's challenges and opportunities in advancing health equity, awareness of the economic case for health disparities reduction. And we're pleased, we're going to be hearing from Dr. Brian Smedley from the Joint Center of Political and Economic Studies, and Dr. Madeline Shea. She is the Vice President of the Population Health Center at Delmarva Foundation, the QIO. And we're going to be talking about the little bit bigger picture and issues and how we can really impact from a healthcare perspective. And next slide, please. Do watch for the HHQI BPIP survey. We do surveys after the BPIP's been out for a little while to get feedback to help develop the next packages, and really making sure that we're meeting needs that you have at your agency. So the survey should be sent, actually, we just got a date change yesterday, so it's going to be sent on the 1st of October by email, and it just takes, really, I put 5 to 10 minutes. It takes less than 5 minutes because this is one of the focused packages. It was very small, I believe 24 or 25 pages only. And we really want to thank you in advance, but something new that we are doing, we have a recognition certificate that you'll receive. So when you finish the survey, you'll click, there'll be a button for you to click to receive a recognition certification for doing that, because you really are helping to develop programs for our CMS-funded programs. So we really wanted to thank you. And I don't have a slide, but I don't want to forget the announcement that we actually just found out at 1 o'clock that we could announce today. The Visiting Nurse Association of America, VNAA, we have actually, our team has been working with them for 6-9 months now on working on a best practice educational package. I mean, an online web-based tool to provide tools and resources, and there'll be webinars, and there's going to be all kinds of great pieces that they're going to, it is going to go live tomorrow, and they will continue to add to it, and it is going to be free. So this is a great resource for agencies, especially small, medium agencies, or you have very limited budget, or you haven't been, there's just a lot of different topics. And I believe there are 10 best practices that will go live initially, and the work group that we're meeting again, we're going to be looking at technology, including telehealth is another one. But do visit the site or mark it down for you to go and to sign up. It is free. It is free for any agency. It does not matter if you're a profit, nonprofit, if you're part of the VNAA or not. This is something that they felt was extremely valuable to provide services and are willing to do that for free. So I wanted to let everybody know. And I think their website is vnaa.org. And the next slide, please. We didn't mention this on our last call too, but in case you were new, we have just started, this is also groundbreaking for, especially for home health, a home health cardiovascular data registry. We are currently working on cardiovascular health. We had our first best practice package that went live in August, and the next best practice package that will come out on November the 1st. But in addition to the packages and the education that focuses on reducing heart attacks and strokes using the ABCs, we have a home health cardiovascular data registry. It is brand new. It is pioneering. CMS is extremely interested in this, and agencies only need to collect very minimal cardiovascular-related data for their charts. And we know from our OASIS you have very limited cardiac of any type of questions that are there. What we do pull is all of the data and information that we can pull from the OASIS, such as the identifying number, their diagnoses, and different pieces that we can gather. And you're only asked between a couple questions to, I think, 7 is the max on a patient. It depends upon their diagnosis and the grouping that they're put in. This is we are going to be doing a study for them, and you will get specific reports for your agency that are not available to any other agency. If you are interested in participating in this, please contact us at the HHQI website with our contact, which is our at our email, hhqi@wvmi.org, or anywhere on our website, there's contact us. And we'd be happy to get somebody to call you and to explain a little bit more about the program. It is free. You'll get free reports. It is only for CMS reporting agencies. And we really are looking for agencies who also serve the African American population, Hispanics, Asians, but anybody can participate in this project. So we'd love to be able to talk with you a little bit more. We've had great success with working with agencies to do this so far. And next slide. And our next live chat, if you've never participated in a live chat, it's once a month, and it's going to be on the 18th of October from 2 to 3 Eastern. It is a 1-hour chat. There's no audio. You just click and log on, and then you can type in your questions. It can be, we sometimes usually have a theme, and this next month is going to be disease management, falls, and care transitions. That's what we were requested by the people participating last time. But we take any questions, and we come up, we find you some ideas, tools, resources, and we go back and forth. And it's kind of fun, and you learn a lot of information and can get some really good resources. And you can register, you don't have to register for it ahead of time, but you can register for a reminder to join. And you just need to go on our website under networking, and there is a button that you can ask for a reminder a day before, 15 minutes before, whatever you want, just to remind you. But it is fun, and it is a good learning opportunity as well. And next slide. And if you haven't joined us, we are on Facebook, and we have lots of postings, and it's been fun. We do also have agencies that send in pictures a lot of times of their posters or their bulletin boards that they've done based upon the work that they're working on, and anything that you might be doing that's exciting. We love to have pictures posted here, or any kind of comments or anything that you'd like to, and sign up to get some notifications of announcements as well. And the next slide, please. And that's our thank you. We thank you very much. We're at the top of the hour, so we thank you for your time. And we would, the handouts are available, and I did forget to mention that, I'm sorry, on the UP event page under archives. You can get the slides from there. And we thank you very much.
Thank you.
Thanks.